from the cells into the GI tract, causing gastric pain, distension, bloating, flatus, but it's also drawing that fluid, so you're going to have increased stool and liquidity of the stool. So diarrhea, like those, right? We have increased frequency and liquidity of the stool. So what do we want to do? Well, the main thing is you want to decrease the amount of lactose as possible. And once they reach a year of age, you can actually give Lactaid, and they have other kinds of different oral drops that they can actually give if you think they're going to come in contact with something that has lactose in it. So for example, if you have a child that's going to a birthday party that is going to have like ice cream cake or something, just as an example, they might give Lactaid beforehand, and then they can actually have some of that, some of the lactose, not a great amount, but they can still have something with lactose in it, and it will help. It's synthetic, but it will help to balance it so they won't have such severe symptoms. But for the most part, they have to remove it from their diet. And all of these things cause something called gastroenteritis. How many students this semester have cared for pediatric patients with a diagnosis of gastroenteritis? Anybody? I know my group has. Nobody? At North Bath, you haven't had any like gastroenteritis, dehydration? Well, that's a big... The two big reasons why infants get, or any child gets admitted to a hospital is respiratory. Obviously a bronchiolitis, some kind of respiratory incident, exacerbation of asthma. And the second biggest is dehydration due to gastroenteritis. What causes gastroenteritis? Because everybody in this room at some point or another has probably had an episode of gastroenteritis. What is it? And what is it caused by in some cases?
Bacteria.
Very good. Bacteria. Salmonella is a big offending one. So for example, if I have chicken I leave out, or I have food that I leave out, and then I eat it, that will cause these symptoms. What else causes these symptoms? How about you have a patient, you give them antibiotics. This is the number one thing students tell me, right, as a side effect when they give antibiotics, and I say to them, well, what do I have to watch with the antibiotic? What's the first thing students tell me? Gastroenteritis, right? Nausea, vomiting, gastroenteritis. Why does that happen with antibiotics? Okay, good. When you kill the normal flora, then they're not able to fight off, and you actually have more, and the normal flora actually helps to digest, so then you have more gastroenteritis. What were you going to say, Talib?
Other pre-existing GI conditions.
Okay.
Also
That's right. Those kind of things too can cause gastroenteritis. Stress. If I'm stressed and my fight or flight response is up, that will cause me to empty, go quicker, go to the bathroom, right? Empty my intestines to help with the fight or flight response, actually. There's theory behind that. So stress. So it can be benign, it can be self-limiting. Things like rotavirus is a very common virus. Mostly it's viral in nature, unless it's like a food or something. But mostly gastroenteritis is viral in nature, which means it becomes a very big thing for children in preschool age and school age, because they're not always doing the best hand hygiene, and they're touching everything. And so that can become an issue.
That's what I was going to say. Isn't it controversial about giving broad-spectrum antibiotics because it's mostly viral in nature until you find the culture and sensitivity that you don't want to remove?
When an infant or a child comes in with gastroenteritis, dehydration, and many of you have seen this too, really the only thing they put them on are IV fluids. And maybe Tylenol in case they have a fever. But the rest, they don't put them on antibiotics if it's gastroenteritis. Now, if they believe it's respiratory, or if they believe it's a UTI or something like that, then then they're going to start them on broad spectrum. But if it's purely gastroenteritis, they have vomiting, nausea, diarrhea, those kind of things, and they're dehydrated, they're just giving them fluids to replace that, and then and monitor them and Tylenol.
You're saying antibiotics can cause this.
That's right.
Not just get them for it. You could have a strep throat and get
That's right.
antibiotics, and then you're getting strep.
Correct. That's right. They don't usually give the antibiotics though to treat this. I just wanted to clarify that. But yes, as a causative agent, they could have something else. They get into the antibiotics, and this causes it. But they don't get antibiotics when they have this. Usually, it's just the fluids that are being replaced. So if I have an infant that comes into the ER with episodes of vomiting and diarrhea, what makes me put them into the hospital? That's what you want to think about. What makes them have to be hospitalized? Because all of us have had episodes of vomiting and diarrhea, but not all of us have had to be admitted to the hospital for it. Good. Everybody see it. Well, how do I know they're dehydrated? responds.
Sunken eyes.
Good, sunken eyes.
Dry mucous membrane.
Dry mucous membranes. Skin turgor.
So the temperature goes up?
Slightly. Sometimes they can have a slight temperature increase. Sometimes even higher too if their body's responding to the infection.
Heart rate, respirations goes up.
That's
They
right,
go
heart
up.
rate, respirations are going up, and Marie.
Decreased urine output.
Decreased urine output. Sometimes you have an increased hematocrit. Is that what you're saying, increased or decreased? Increased because the body will try to, because when you have less circulating volume to the kidneys, right, it goes back to like what we talked about before, less circulating volume to the kidneys, they're going to actually increase red blood cell counts. So sometimes you see that, which is like a polycythemia, or sometimes it's decreased depending on the child and their compensation. Older children, you see the increase, school age even.
And all the symptoms we see with hypovolemia actually.
Yes, you can even see that if it's severe, symptoms of hypovolemia, like you were saying with the heart rate and the blood pressure. So what makes me keep them?
Higher uranic gravity.
Yes, urine-specific gravity becomes high, more concentrated, right? Because there's actually, and less urine output even if it's really severe. Your book has a great chart that goes through mild versus moderate versus severe. And what I will tell you is if they see moderate or severe signs and symptoms, they're going to keep them. And if they see even mild symptoms and they are not taking in orally, they will keep them. Because that is a key too. A lot of times they'll watch them in the ER. If they're not taking in fluids, or if they're taking them and they're vomiting right up again, then they're going to keep them. Because that is key. You have to be able to go home and tolerate fluids. If they're not able to go home and tolerate fluids, they have to stay and get an IV. And that is the key. So, so again, that's actually the key there. I'm going to jump ahead because I have it, when I talk about diarrhea and increased frequency of stools over here. Here. So this is what you see. So again, antibiotic use, unwashed hands, rotavirus, salmonella. The smaller child, the less fluid in each body compartment. So again, there's loss of salts, sugars, and you can actually see a metabolic acidosis as a concern of diarrhea because you're losing what? Well, a metabolic acidosis means you're retaining, right, you're losing bicarbonate. When you have diarrhea, you lose bicarbonate. When you have vomiting, you actually lose the acid. And then you have a metabolic alkalosis. Again, think of what you see with those. So vomiting, you can see a metabolic alkalosis. Diarrhea, you can actually see a metabolic acidosis because you're losing bicarb in the GI tract. Further down in the GI tract is where you have more of the bicarb. Does that make sense? Okay, so then you're going to see respiratory compensations for those. This is all the way at the end. I want to jump to it now because this is what we're talking about. So again, when you have dehydration due to any of these, you have sudden rapid shifts, imbalances. And when you estimate the dehydration, how severe it is based on how much fluid they have lost. So if they're starting to lose weight, then that's going to be obviously a greater amount of fluid loss. How do we hydrate? How do we assess hydration status? All these things you guys were talking about. Skin color, skin turgor, tears, thirst, activity level. And what do we do for fluid replacement? Well, we always want to have an oral rehydration solution. Brat diets no more carry a lot of weight in the clinical setting, although sometimes we do see them used in the clinical setting. They're not really valid. What they like to see happen is that the infant can tolerate clear liquids to start. And then they try things like Pedialyte, water, Pedialyte, clear liquid, but something to replace the electrolytes. While they give them an IV, okay, to replace their fluids that way too. Now, somebody will say, I have an older child, they don't want to drink the Pedialyte at all, but they'll drink Gatorade. What should I do? You're laughing, Talik. You can give them the Gatorade. Well, is it any better than Pedialyte? Should I force the Pedialyte on them? Actually, Gatorade and Pedialyte are the same. They're pretty much the same in consistency. So a lot of times people will say, yeah, they're pretty much the same in consistency. So if they take the Gatorade, there's a lot of studies on this too. If they take the Gatorade, that's great. And most times they'll drink that better than they'll drink the Pedialyte.
My wife takes Pedialyte when she's fasting, and she says it tastes like bad BO.
Yeah. That's the problem with Pedialyte.
Gatorade tastes a lot better.
That's right. And they're the same consistency. They have the same things in them. Actually, if you hold them side by side and look, they did a lot of nutritional research that came out, and they're the same. So more people respond to the Gatorade. And they have more variety, so they say just give them that if that's what they'll take.
Which one's cheaper?
Pedialyte's very expensive, exactly. Oral rehydration solution is what's gonna, again, it doesn't decrease the number of episodes or volume, but what happens approximately every 4 days is that you shed the lining of your GI tract. So if you truly have an infection or something going on in there, you shed that lining every 4 days. So they usually say it's self-limiting with these diagnoses. Very self-limiting. The only thing they probably would give, especially if the vomiting's increased, is what? Anybody have a thought? That's right, Zofran, or an antiemetic. Some kind of antiemetic they'll try to give. And the other thing you always want to watch for is, if you have a patient that's actively vomiting and they are febrile, then obviously you need to get an order for PR or rectal along with the PO. Because you can have the PO Tylenol order, and many times the doctors automatically write that, obviously, but how are you giving it? If you're going to give it and they're just going to vomit it up right away, then you need to have the other route that should really be written there when they're admitted. Might not have to use it because they might be starting to retain, but you want to have that availability if they're actively vomiting. Okay, so IV therapy, again, to replace it. And rat diets, which were the bananas, rice, apples, tea, and toast, you might see it clinically, but it's still not the most recommended. And then, again, medications, really, they do not need medications. This is from years ago, they've said that. So what do we want to do? We want to assess hydration status, assess the stools, educate family, especially educating family on what? Hand hygiene. It's really all about that, because there's other children that might be in the house themselves. It's really about, containing, because they might be going quite frequently. So keeping them clean, especially like it says there, the anorectal area. Very common to have diaper rashes, or diaper dermatitis, what we call. Very common to have this with this diagnosis, because these are highly acidic fluids that are going to be against the skin area. Dark, warm, moist environment can turn into another infection, right? So that's why we really want to protect skin breakdown.